Hello, my dear student. In this part, I want to talk about airflow, pressure gradient, and resistance, and the relationship. The airflow is the amount of air moving in and out of our lung in each breathing. And the airflow depends on the pressure gradient established between atmosphere pressure and intrapulmonary pressure. I told you that when the atmosphere pressure and intrapulmonary pressure are the same, we don't have any airflow. When the atmosphere pressure is more than the pressure in our lung, we have inhalation. And when the pressure in our lung is more than the pressure outside, we have exhalation. So it can affect our airflow, and the resistance can affect our airflow, and it occurs due to different conditions which we have in our airways, in the lungs, and also in our chest. The pressure gradient can be changed by change in the volume of our thoracic cavity. The small changes in the volume in our quiet respiration can help about 500 milliliter of air to come inside and 500 milliliter to go out. And if we use accessory muscles, if we want to do forced inhalation and forced exhalation, then the volume of our chest increase, and then we have more inhalation, and then the volume of our chest decrease more, and we have more exhalation. So it can affect the airflow, and the resistance becomes greater when we have a problem with moving our air. And it can be changed by the change in the elasticity of chest wall and lung. When the elasticity of our chest wall and lung decrease, the resistance increase, and after that the amount of air which can come inside go down. The change in bronchial diameter, when the diameter of our bronchioles increase, then the resistance decrease and the airflow goes up. And when the diameter of our bronchioles decrease, then the resistance increase and the amount of air goes down. And sometimes we have collapse of alveoli. Some of our alveoli become unfunctional, and their wall collapse on each other when our when we don't have production of surfactant, or the alveolar cell type 2 has problems, and then the resistance increase. Here you can see how the resistance can change the amount of airflow. I talked about the elasticity of our chest, and when this elasticity decreases, the resistance goes up. The chest wall elasticity decreases with aging and different diseases. The vertebral malformation, like scoliosis, can decrease the elasticity, so our chest cannot become expanded enough and go back to its original shape normally. When we have arthritis in thoracic cage, when we have inflammation of the joints which we have between our ribs and sternum, and between our ribs and the vertebrae in our vertebral column, then this elasticity change. And when the elastic tissue replaced with the scar tissue, like the pulmonary fibrosis, when the elastic fibers in our lungs disappear, and instead of them we have formation of fibrous connective tissue, the fibrous connective tissue cannot expand and recoil back. So again, the elasticity comes down. And the bronchioles or bronchioles diameter can change this airflow with changes in the resistance, and they are related together inversely. When we have bronchoconstriction or occlusion means blockage, the resistance increase, and it happens by parasympathetic activity when we have release of histamine from our mast cell or basophil, and when we have cold. At the time of inflammation, we have bronchoconstriction, and also in asthma we have bronchoconstriction too. And when we have occlusion, when you have inflammation, and these inflamed bronchioles can block the air passageway, or when we have production of more mucus than normal, we have this problem. And bronchodilation can decrease the resistance. When the diameter of your bronchioles increase, then the resistance come down, and it happens by sympathetic stimulation and epinephrine. And sometimes we have collapse of alveoli, and it can increase the resistance. And it happens when the alveolar cell type 2 cannot produce enough surfactant. I talked about the wall of the alveoli for you, and imagine that if this is your alveoli, due to presence of water molecule, these two sides of the wall likes to attract each other, and the wall is collapsing on each other. But due to release of surfactant from alveolar cell type 2, the water molecule cannot attract each other, because this is the oily secretion and nonpolar, which cover the water molecule, and it doesn't let collapsing. And we have it in newborn specifically. Sometimes if they are immature or premature, then their alveolar cell type 2 cannot make enough surfactant, and we have problem with this resistance. And when we have collapse of alveoli with expiration, it can increase the resistance, and we have a condition which we call it ARDS, or acute respiratory distress syndrome. At this time, all of our alveoli in one part of the lung collapse on each other, and by this collapsing, the resistance goes up. And the other term which we have for our lung is called compliance. Both the surface tension and elasticity of the chest wall and lung determine compliance. Compliance is the ease with which the lungs and chest wall can expand. The easier the lung expansion, the greater the compliance. In contrast, the more difficult it is for the lung to expand, the lower compliance which we have. And several conditions can increase the resistance to airflow. The respiratory diseases and anatomic abnormalities can increase the resistance to airflow, and they are associated with either the decrease in the size of the lumen of bronchioles, which we have in asthma, or decrease in the compliance when we have pulmonary fibrosis, or both of them. These changes produce an increase in resistance. If enough airflow to be maintained, the increased resistance must be met with more forceful inspiration to establish a steeper pressure gradient. And can cause, when you want to do more forceful inspiration, you should use more energy. The amount of energy which you need is 4-fold to 6-fold increase in the amount of energy. And from 5% to 25% of your energy which you have in your body is used by forceful inhalation and exhalation when you have resistance in your airways. And in these conditions, the individual and the patient become very, very exhausted. And the other term which we have in the respiratory physiology is the pulmonary ventilation and alveolar ventilation. You know that the ventilation is the process of moving air inside and outside of the lung. The amount of air moved between the atmosphere and the alveoli in 1 minute is called pulmonary ventilation. When we want to calculate the pulmonary ventilation, we need to have two different factors. One of these factors is called tidal volume. Tidal volume is the amount of air which comes in our lung in each breathing. And this amount of air in normal person is about 500 milliliter. And the respiratory rate is the number of breathing per each minute. In normal person, it's between 12 to 15. And when we multiply the tidal volume by respiratory rate, we can have our pulmonary ventilation. And here, if our tidal volume is 500 milliliter and the number of our breathing is 12 breaths per each minute, our pulmonary ventilation is equal to 6 liter per each minute. When I talked about the divisions of our respiratory system, I told you that some parts of our respiratory system is called conducting zone and the other part is called respiratory zone. And the description of each of these parts is this. The conducting zone can only conduct the air and we don't have any exchange of oxygen and carbon dioxide. And the respiratory zone is a part which can do this exchange. When you do inhalation, about 350 milliliter of air goes to your alveoli to do exchange and 150 milliliter remain in your anatomic dead space or conducting zone space. So the anatomic dead space is the conducting zone space. No exchange of respiratory gases happen here and it's about 150 milliliter. And when we want to calculate our alveolar ventilation, we need to know the amount of air which come to our respiratory zone. So you need to subtract the tidal volume from, the anatomic dead space from the tidal volume. This is the amount of air which you have in your alveoli. And if you multiply this number by the rate of respiration, you have alveolar ventilation, the amount of air which reach to your alveoli in each minute. So what happened here? For alveolar ventilation, you need to know the amount of air which you have in your alveoli. So if your tidal volume, the amount of air which you inhale, is 500 milliliter, and the anatomic dead space is about 150 milliliter, the alveolar ventilation is calculated by this formula. The tidal volume minus the anatomic dead space times respiration rate. And when we have deep breathing or forceful inhalation, the amount of our alveolar ventilation increase. The physiologic dead space is the normal anatomic dead space plus any loss of alveoli. Some disorders decrease the number of alveoli which participate in gas exchange, and this is due to damages which we have to our alveoli, or when we have pneumonia and the thickness of our respiratory membrane change, so the amount of air which can go to our alveoli decrease because our alveoli cannot become expanded enough at that time. So physiologic dead space is the normal anatomic dead space plus any loss of alveoli. We have a device and we have a process which we call it spirometry. The spirometer is a device which can measure the respiratory volume for us. The other name of a spirometer is respirometer, and that can be used to access the respiratory health when we want to see if that person, the specific person, have normal respiratory system or not. We have some measurement when we want to do this access. Look at here. This is the graph of a spirometer or respirometer. And in this graph, you have different parameters. When you are doing normal inhalation and exhalation, your graph is like this. Look at here. You can see this part can show us normal inhalation and exhalation. We call it tidal volume. Tidal volume is the amount of air inhaled or exhaled per each breathing during quiet breathing. Sometimes you do forceful inhalation, and here you can see the forceful inhalation. Look at here, you see that you can inhale more air. This amount of air which you inhale more than normal is called inspiratory reserve volume. Here you have the name. Inspiratory reserve volume is the amount of air that can be forcefully inhaled beyond our tidal volume. Sometimes we do forceful exhalation. Forceful exhalation is here. When you exhale more than normal, when you exhale beyond the tidal volume, this amount of air which goes out is called expiratory reserve volume. So, first we have tidal volume. Tidal volume is the amount of air which you inhale and exhale in normal situation. Inspiratory reserve volume is the amount of air that can be forcefully inhaled beyond the tidal volume after a normal inspiration. And you need to know that this inspiratory reserve volume is a measure of our lung compliance. It can show us how our lung become expanded to accept a large amount of air. And expiratory reserve volume is the amount that can be forcefully exhaled beyond the tidal volume, and it happens after normal exhalation. Expiratory reserve volume is a measure of lung and chest wall elasticity. And finally, here you can see residual volume. Look at here from 1 to 1000. The residual volume is the amount of blood left in your lung after the most forceful exhalation. I told you that due to the higher intrapulmonary pressure than the intrapleural pressure, all the times our lungs are inflamed. And we have a small amount of air in our lung all the times, although when we are doing forceful exhalation, this amount of this amount of air is called residual volume. These are the different volumes which we can measure by a spirometer. And in the lab, I will talk about it a little bit for you. Then we have some capacity. We have 4 different types of capacity which can be calculated by this respiratory volume. One of them is called inspiratory capacity. Look at here. Here you can see inspiratory capacity. The inspiratory capacity is the sum of the tidal volume and inspiratory reserve volume. We call it inspiratory capacity. The other capacity is called functional residual capacity. This is the sum of expiratory reserve volume plus the residual volume. It is the volume of air that is normally left in the lung after a quiet expiration. And the other capacity which we have here is called vital capacity. Vital capacity is the sum of inspiratory reserve volume, tidal volume, and expiratory reserve volume. We call it vital capacity. You need to know that the residual volume is not a part of your vital capacity. Vital capacity is significant because it's a measure of the total amount of air that a person can exchange through force breathing. And finally, you can see the total lung capacity, which is the sum of all of these volume, and it includes the residual volume too. And this is the maximum volume of air which your lung can hold. So we have 4 different volumes and 4 different capacity for our lungs. And now you can answer this question. These questions. What is Boyle's law and how does it relate to respiration? Which muscles are involved in quiet respiration and what nerves can control them? To what chemical signals is the body most sensitive with regard to respiratory control? What parts of the brain can control the respiration? And what is the vital capacity? I will talk about the alveolar and systemic gas exchange in the next video for you.